I am delighted to present on selective dorsal rhizotomy for spastic cerebral palsy. And this the work has been going on for 32 years, since the time at the University of Virginia. And I will briefly describe what I have done and for treatment of spastic cerebral palsy. So the diagnosis of cerebral palsy, there are three criteria for diagnosis. One is the onset has to be early, that is during infancy. If the child had a normal motor milestone for 2 or 3 years, then show the symptoms of motor impairment, then that's not the cerebral palsy. Number two is there has to be impairment of motor, and basically motor in the posture disorder. I'll show you later, and that's the second criteria, motor and the posture disorder. And the third criteria is the brain lesions that cause this the cerebral palsy has to be static. It shouldn't be progressive neurological disease, such as leukodystrophy. That's not that cannot be the part of the cerebral palsy. So that's the leukodystrophy stands alone. That's separate. We do not include that progressive disease under the umbrella of the cerebral palsy. So that's a general diagnosis of cerebral palsy. Now so it's a clinical diagnosis. And there are subtypes of cerebral palsy. First one is a spastic. It's not the most common, but one of the common cerebral palsy is a spastic. Spasticity is present in about 80% of all patients with the cerebral palsy, but there should be a dominant problems with the motor function, and one is a spastic diplegia. That means the lower extremities are involved, upper extremities are normal or minimally affected. Triplegia, 3 limbs are involved, both the lower extremities and the 1 upper extremity is involved. Quadriplegia is body, total body, and all 4 limbs are involved. Hemiplegia, one side is involved. They use the diplegia. Hemiplegia is not it's not plegic. It's not flaccid, as we see in other conditions. It's just that the terminology used by non-neurology and the neurosurgery, and it was developed many decades ago, and still we use this diagnosis, the name of the diagnosis. And there is dystonic CP, ataxic CP, and the mixed CP. Mixed CP can have spasticity, dystonia, or ataxia all together. So that's the subtypes. And it's important to distinguish the subtypes of CP for treatment. So in general, in cerebral palsy, there are 3 problems. One is weakness, motor impairment, and the motor weakness. The second is a spasticity, and the third is a deformity. They developed various deformities. Now, the adverse effects of CP spasticity, there are multiple. One is spasticity inhibits motor development in childhood. The movements in daily activities are inhibited by the spasticity because they are so stiff and they cannot move as much as they should. They cannot do the exercise because spasticity is a velocity dependent increase in muscle tone. So when they move fast, the spasticity increases and the exercise is limited. The muscle stretching is also inhibited by this spasticity. In children, developing children, muscle growth is inhibited by the spasticity. And muscle growth, muscles grow in children by stretching. Stretch is the most important the factor for the muscle growth. And this muscle growth is inhibited by the spasticity. This video shows a typical gait pattern of spastic cerebral palsy. The child has a crouched knees and very stiff movements, and also walks on tiptoes in a walker. So that's a typical presentation of the spastic diplegia. Also, cerebral palsy spasticity causes premature aging. This is known among CP community, but we have better understanding of this phenomenon among adults with spastic cerebral palsy. Basically, premature aging is caused by the spasticity, and the onset can be as early as late childhood, for example, puberty or teenage age. Then muscle strength declines, their endurance also declines, and so the mobility declines. They cannot walk, and they develop severe muscle and joint pain, body pain. The vast majority of patients with spastic cerebral palsy lose the ability to walk by the age of 50. And here is the video of a patient. She had surgery at the age of 49 years of age. Her early walking and activities at 2 years of and early childhood, then later developed this problem. This you can see this how this evolves. And after the selective dose rhizotomy, she improved, and she resumed this independent walking, and she has become a very active mother. So this is one example. Is there any benefit of CP spasticity? There is none. Patients, both adults and children, do not use spasticity for their movement. And contrary to some of the opinions in CP community, I have ample evidence to support my claim. Now, patient selection. Who are the candidates for this surgery? At our clinic, the patients between 2 to 50 years of age. Subtypes of CP, spastic diplegia, triplegia, quadriplegia, hemiplegia. There should be potential to improve mobility and the quality of life. Now, potential, how do you know the potential? And there are so many factors, but I cannot go in detail here during this video presentation. But I have to see potential for them to improve mobility, walking, and quality of life. Not suitable for this surgery. One is if they had devastating neonatal meningitis, severe head trauma, or any kind of head trauma, is not a candidate for selective dorsal rhizotomy, at least at our clinic. If a child had a global hypoxic ischemic insult, for example, drowning, because they have mixed CP, including rigidity or dystonia, we do not take these patients. If the patient has predominantly dystonia with some spasticity, they are not the candidates. If they have, if the spasticity is predominant and there is some degree of dystonia, they can be candidates. The severe spine deformities, especially the kyphosis or scoliosis, severe. The mild spine deformities can be can be a candidate, but if the spine deformities are severe, we do not offer the surgery. If there is over-lengthened Achilles tendons, they will have a permanent crouch knees, and eventually they lose they cannot walk because the knees are getting crouched and crouched, because the Achilles tendon is over-lengthened and there's this tibia cannot be supported over the foot, and they just slouch there. So that's one contraindication. No potential for functional gains. Again, I mentioned this. If there is no potential for functional gains, mostly if the child has a severe cerebral palsy, severe weakness, and we do not recommend the surgery there. Now, I will show you, this slide shows age at the time of selective dorsal rhizotomy in our patients. Between 1987 to 2019, this week, we have performed 4,323 selective dorsal rhizotomy. And the age distribution is between 2 and 3 years is over 1,100 patients. Between the age of 4 to 6, over 1,800. So total, about 70% of these patients are between the age of 2 and 6. My personal opinion is the best age for this surgery is 2 to 3 years. I just completed, did the one 2-year-old child from Serbia before I came over for this presentation. So this slide also shows we have performed the surgery on 166 adults between the age of 19 and 50. So that's the age distribution. Now, subtypes of the spastic CP, this slide shows diplegia, diplegic patients 78%, quadriplegic patients 12%, triplegia 7%, hemiplegia is 2%. So that's it, the distribution of subtypes of the cerebral palsy. Now, the mobility level before surgery. We have done surgery on over 1,600 independent walkers. They walked independently before surgery. We did the surgery to improve the quality of mobility and the other motor movements, and to prevent future deterioration, namely premature aging process. Crutch walking, walking with the walker. Then second group is the walking with the walker. These are young children who walked with the walker, and we have done surgery on children with this. There are some small number, 32 patients with no independent movement. These patients, we knew their improvements will be minimal, but basically to make this care easy, patient care and the comfort, we do the surgery. But please note that we do very rarely this type surgery in this type of patients. Now, the 85% of our 4,323 patients were prematurely born. So that's a premature birth is the main group. For some reasons that we do not know, this selective dorsal rhizotomy works well for these prematurely born patients. We have done surgery 13% of the patients who were born at full term, and they were born at full term, and the MRI is normal, and there's no problem with any with their birth or before birth or after birth or during birth. And we do not know why they have a cerebral palsy. And these patients, it's a separate group. separate group. There's 13%. And one of the few problems with these patients, sometimes they show the symptoms of other neurological disorder later. For example, mitochondrial disease or hereditary spastic paraplegia. Another problem is this: for the reasons we do not know, the spasticity can return in some patients who are born at full term. This does not. It's very, very rare to see return of spasticity among children who are born prematurely. Very rare, extremely rare. But these full-term birth, I think 1 or 2% of the patients can have return of spasticity. So that's the kind of distribution of the patient selection. Now, surgery. The STL is the only treatment that can eliminate the CP spasticity permanently. There are a number of CP treatments, Botox, baclofen, and medications, and so forth. None of them can eliminate the spasticity permanently. And selective dorsal rhizotomy is the only treatment that can remove the spasticity permanently. This is a very important distinction and advantage of the selective dorsal rhizotomy. So this slide shows my STL procedure. We published this in 1991. And when this procedure was introduced to this country by Warwick Peacock, and the operation required multi-level laminectomy from L1, L2 to S1 or 5, 6 levels. And I was concerned about the negative consequence of multi-level laminectomy, and I modified this to single-level laminectomy. And here it shows the surgical procedures. I will show you more about the details of surgery. This slide shows the electrodes placed in the 5 major muscles in the lower extremities for intraoperative EMG studies. And this slide shows tracing, EMG tracing during the tetanic stimulation. So first we determine the threshold and then deliver the tetanic stimulation at the 50 hertz, the rate of 50 hertz. And we see this multiple muscles responding to that tetanic stimulation. And we grade the responses, EMG responses, and determine and decide which nerves should be severed. Here is the laminectomy site. Typically, in young children, we do the one-level laminectomy. That's about a couple of inches, about 2.5 inches of laminectomy site. I do not do the laminoplasty because these children can regenerate the bone and form this lamina in several years. And I have not seen any benefits of laminoplasty. As a matter of fact, I have seen more problems from laminoplasty on other patients. And these slide on the right side top, we open the dura, and we see this dorsal roots there, and on the lateral side, the root that is L1 dorsal root, and we retracted this dorsal root medially. Then on the third slide, you can see this. The spinal cord between the dorsal roots and the ventral roots. So there is a separation there, and once we separated that, pad is placed laterally, Then we come to the medial side, and as you can see in this slide, the nerve root, dorsal root is elevated, and you can see this sacral nerve roots, S5, 4, 3, and probably the part of S2. And we leave this S3, 4, 5 dorsal roots, and some cases in the S2 also. S2 is left behind. Then we know the space there. You can see this on this slide. We place this blue Celective sheet under the dorsal root, and so it starts from the medial part and it comes out, and here is the lateral part. On this last slide, this Celective sheet is on the shown on the lateral side. So all dorsal roots are placed over the Celective sheet. No ventral roots should be over the Celective. So once this is done, there is no manipulation of ventral roots. Then you can see this is L1. Now the question is, how do you know this is L1, L2, L3, L4, L5, S1? We can easily determine we can locate this L1 dorsal ventral root. Then if you go the distal part, the caudal part of the dorsal roots, there is a separation between the L3, L4 dorsal roots. Separations. You can separate. Then you can come up toward the conus, and that way you can separate. And then L5, S1, in general, they are together, and we divide them into two, almost equal size. So that's the way we do. Even if there is a little bit of overlap, a little bit, let's say, sometimes it's not clear cut. Even if the separation is not clear, in the spinal cord there is a massive overlap. The synaptic organization is overlap. For example, L5 nerve root goes projects the dorsal root fibers all the way to the lower thoracic region. So it's the same, it's overlapped. So it really doesn't matter whether you even if you not clear cut in location separation of the dorsal roots. So once it's done, we use the sharp instruments, and we divide them into 3 to 5, or 2 to 5, depending on the size. In general, I don't go. I rarely do the 5. The rootless. We make 5 rootless. In general, about 3 to 4 rootless would be adequate, because if we try to separate this too many, I think it's probably inflicts some trauma, and also it may not make any difference in the outcome. So it takes a longer time. So the 2 to 4 rootlets we generate from each root, the dorsal roots. And after surgery is done, we close the dura with the running suture combined with the interrupted the sutures, and we place this epidural catheter for postoperative pain control. This epidural analgesia has been a tremendous help for these patients, because they can be really pain-free without these, it has been extremely difficult it is very difficult to control the pain. Some people claim that they can do that with ibuprofen and some Tylenol, and in my experience, it has been very difficult. So they need to be pain-free. This epidural analgesia has been it works very well for them. Another treatment of another aspect of the treatment of these patients is they have deformities, short muscles and tendons. So the orthopedic surgery, correct orthopedic surgery on time, in a timely manner, is also very important for the outcome, because SDL alone cannot stretch out this the contracture, muscle contractures and tendon contractures. So this slide shows my orthopedic colleague, Dr. Matthew Dobbs, developed minimally invasive tendon lengthening orthopedic surgery. So in our together we performed this orthopedic surgery early on international patients. We do surgery, orthopedic surgery within 10 days after selective dorsal rhizotomy, so that they can really have a much better posture in walking or function. So this is the important one. Now here is the slide. I'm showing the video of one child who shows the before and after movements. This mother created this video, and it clearly shows the difference. This second video shows another child who had the selective dorsal rhizotomy and minimally invasive orthopedic surgery. We call it the PERCS. And you can see the difference here. This third child, this is what the video shows: the extreme toe walking, extreme crouch knees, and we did the surgery. He was basically in a wheelchair. We did the STL and the orthopedic surgery. After that, this is the video shows almost normal walking. And still, we did the surgery about 10 years ago, and he's in college, and he didn't have any more orthopedic surgery. He's doing absolutely great. So the SDL outcomes, there were 85 outcome reports between 1990 and 2017. These the reports emanated from many countries, number of countries, different countries. And I reviewed these reports, and the results are overwhelmingly positive. That's the general outcome. We also performed our own study, short-term study and long-term study. In 2006, we published this outcome of the short-term functional outcomes after the selective dorsal rhizotomy. And this study was funded by NIH. And this is one of two NIH-funded SDL study. We had a total of 97 patients followed for 2 years, and the groups were 3 groups. One is SDL plus PT, and PT alone, and no treatment group. And this the patient cohort is the largest of any other the control studies. And we quantified the spasticity, motor strength. And the spasticity was reduced in the SDL plus PT group, and motor strength did not change after selective dose rhizotomy. In other words, they were not weakened. The surgery did not decrease the strength. GMFM, gross motor function, improved in SDL and PT group. And we also conducted the gait analysis to quantify the gait parameters, and they were all improved in SDL and the PT group. The long-term study, we published two long-term studies in 2017, and we also published this functional outcome of selective dose rhizotomy on adults. In 2019, we published. Now, the long-term study of functional outcomes of children, and we did a survey. That's the only way we can do any long-term study. Survey of the patients who had the surgery between the 1987 and 2013. And the patients who reached the adult age, 18 years of age. And there were 810 potential participants. Some patients we couldn't, we don't have the email address or the mailing address. So of these 810 potential participants, 36% responded. That's about 20 or 30 years is quite good response rate. And this slide shows follow-up period. We followed up to 28 years. And this slide shows age at the time of survey. So we did these patients had the surgery as a children in childhood, and now they reach the adult age. And so at the time of survey, they were the age range between the 18 to 44 years. So the oldest patients was 44 years. So this is a long-term follow-up. And the CP subtypes of these patients, 84% of the patients spastic diplegia, 12% spastic quadriplegia, and 4 spastic triplegia. Overall outcomes, level of ambulation. This surgery benefited them, improved or maintained this independent walking in 83% of the patients. If they did not have STL surgery, the vast majority of them would have lost walking, the ability to walk. So the fact that they maintained it walking or better, that's success. Success rate is 83%. The quality of life, they felt their quality life increased in 88% of the patients. Would you recommend this surgery to others? 83% of the patients say, yes, I would recommend this surgery to others. This is many years after, up to the 28 years later. They say, so this is a perception of STL is very, very positive. They said 3% of them said no. These patients were walking with walker, the spastic quadriplegia patients. Now, some of them were employed, so that's one. The early complications of STL, early complications between 1987 and 2019, of 4,323 wound infection that required readmission occurred in 4 patients. CSF leak and repaired in 7 patients. So that's the early Of course, there will be some local infections, wound infections, for example, but they didn't require any readmission there. The late complications of STR. The two patients developed the T12 and the L1 kyphosis. Those are teenage female girls, and they walked with a great sway gait. And because of that movement, they developed this excessive movement at the T12 and L1, and both of them required spine fusion. There was no patient with the late sensory loss, any significant sensory loss, no late motor weakness. So if they exercise, then they could maintain this independent walking. So that's the outcome. And I appreciate your attention to my presentation. I hope this would help you understand the procedure. Thank you.